All right. Well, good afternoon, everyone. Thank Dr. Marion for giving me the opportunity to present Grand Rounds. And the Louisiana AHEC program does have a program to try and improve HPV vaccine uptake. And this Grand Rounds is part of the program that they've developed to try and educate the practicing physicians and especially residents and medical students about the importance of HPV vaccine as a cancer prevention strategy that provides primary prevention against HPV-related cancers. So I'm going to spend this Grand Rounds time with the following objectives. I want to review the epidemiology, clinical manifestations, and outcomes of HPV infection and make you aware of how common this infection is and the potential outcomes associated with infection. I want to discuss the importance of using HPV vaccine as cancer prevention against HPV-related cancers. Discuss the current recommendations, review recent uptake and safety data, and the recent uptake data is why this is so important for people who practice internal medicine, because there are a number of 18-year-olds and older, 18 through 26, who have not either started HPV vaccine series or have not completed it. So many people will come into your practice who are not fully immunized against HPV or have not even started their HPV vaccine series. So it's very important that you find them and offer them the opportunity to be protected against HPV-related cancer. So that's going to be one of the important things for you who go, those of you who go into primary care in internal medicine, to find these individuals and make sure they're vaccinated. And then I want to show you that not only is this vaccine has proven to be safe, but it's already showing to be very effective. And so I want to show you the early data on effectiveness of this vaccine. So just to review, human papillomaviruses, there are a large number of them. They're very common. We're not going to talk about the cutaneous types of HPV, the common warts that we see on the skin. We're mostly interested in mucosal HPV infection. So these types of HPV, there are about 40 of them, are divided into two groups. There's a high-risk group, and this high-risk group is based on the fact that they have the potential to cause cancer. They're oncogenic types. They have the ability to integrate into the cell replication cycle, cause that cell replication cycle to become increasingly abnormal, and over time result in the development of cancer. And as you can see, the high-risk oncogenic types are responsible for cervical cancer, anogenital cancers, oropharyngeal cancers, a number of cancer precursors, including low-grade cervical disease, which I'll discuss in the next slide. And then there are low-risk types, of which type 6 and 11 are the most common. 6 and 11 are responsible for about 90% of genital warts that occur as a result of HPV infection, plus a rare but really important complication of HPV infection, which we see in infants and occasionally occurs in adults, called laryngeal papillomas, in which the infections occur in the larynx and then ultimately down the respiratory tree and can cause acute obstruction of the airway. And these also are capable of producing low-grade cervical disease. Of the high-risk types, of which there are about 12 or 13, types 16 and 18 are the most common and are the most common associated with a variety of these cancers that I've just described. So this is the PAAP test that we use is really designed to try and find early HPV-related dysplastic lesions. And so for the other type sites where HPV can cause cancer, we don't have an equivalent way to stage early changes, and that's one of the problems with HPV-related cancers at other sites. For cervical infection, we can follow the abnormalities as they develop that progress to the development of cancer And as you can see, it takes many years from the time of initial infection with HPV to the progression through the development of these changes that lead ultimately to the development of cervical cancer. So the PAAP test has been successful because we can find these earlier lesions, and you can see that the earlier lesions are called cervical intraepithelial neoplasia. They're graded as type 1, 2, and 3. Type 2 and 3 are considered to be precancerous lesions. They're now called high-grade squamous intraepithelial lesions, or HSIL, and the lower-grade abnormalities are called LSIL, low-grade squamous intraepithelial lesions, or atypical squamous cells of undetermined significance, or ASCUS. So you can see that it takes many years for this progression to occur. With appropriate screening, you can find some of these lesions early, but unfortunately, there is no medical management of these lesions. If you find abnormal lesions that are precancerous, the only way to treat them is to remove them. So this is where cone biopsies and other things are done to try and remove the infected cells. And so obviously they're invasive procedures. In a young woman who is in her childbearing age range, this can lead to difficulty maintaining a pregnancy throughout an appropriate gestational period and result in preterm delivery and all of its complications. So this is not benign to have these lesions, and can be associated with significant not only psychological but medical complications. So human papillomavirus, this is the most common sexually transmitted infection in the United States. In both men and women, there are estimated to be 14 million new infections each year. And because of the duration of infection, over 79 million people are currently infected in the United States. So that's about a quarter of the U.S., somewhere between a quarter and a third of the U.S. population that's infected with HPV. The highest prevalence is in sexually active adolescents and young adults, and transmission is possible with any type of intimate contact. So it doesn't mean vaginal sex is not the only way this is transmitted. Any mucosal intimate contact can lead to transmission of HPV. The first infection occurs soon after onset of sexual activity, and the lifetime risk of having one or more HPV infections is approximately 80%. So anyone who's sexually active can be infected with HPV. So when we look from the pediatric side, here's the one study that shows the percentage of males and females who've had vaginal sex by age. And you can see that by age 15, a little over 20% of boys and girls have already had vaginal sex. By high school graduation, it's over 50%, and for the adults that you take care of, it's somewhere between 75 to 85% up at about age 20. Now, prior to the development of the vaccine, the CDC began to study the prevalence of HPV in women and later in men. And the reason that it was easier to do in women is because you can test cervical secretions looking for HPV. It's a little more difficult to find HPV in males than it is in females. But starting in 2003, during the National Health and Nutrition Examination Survey called NHANES, the CDC began asking women who participated in the survey to take a self-obtained vaginal swab during the health examination. And this is a group of individuals who are selected because they represent the U.S. population. And by doing that and then looking for DNA for the different HPV mucosal types, you could see that by age 14 and 19, somewhere between about 22% of females were colonized with low-risk types, and about 25% were colonized with high-risk types. So that's how common HPV infection is, even in this young age group. You can see the prevalence peaks in age 20, 24, but up to age 59, which was the oldest individuals in this survey, there is still a very significant prevalence of HPV. So it's across the lifespan that people are colonized with HPV. A couple of years later, it became very clear that HPV was also associated with oropharyngeal cancers. And so in 2009, 2010 surveys, the NHANES survey also asked both men and women who participated in the survey to take an oral wash to look for HPV DNA. And what they found in the age group of 14 through 69, men and women, the overall rate of oropharyngeal infection with HPV was almost 7%. It was higher in men, 10% in men, 3.6% in women, and the prevalence of type 16 in this cohort was 1%. And that's important because virtually all oropharyngeal cancer due to HPV is due to HPV type 16. So 1% of the US population in this prevalence survey was infected with that type. So most people who are infected with HPV don't know it. Most infections are asymptomatic, they're undetectable. It takes about a year for about 70% of the infections to resolve. And some of those changes that I showed you in cervical specimens that occur, some of them will regress. So some patients will have CIN1, CIN2, and then regress as the infection comes under control. But as the cervical changes become more dysplastic, there's a lower likelihood that they're going to regress and a greater likelihood that they're going to persist and worsen. So, but for the majority of the population, within 2 years of or so of the acquisition of a type, resolution occurs in 90%. But it's those individuals who have persistent infection that end up with a cancer outcome. Genital warts, over about 360,000 people seek medical care in the United States each year for genital warts. So that's probably not everybody, but that's those who have manifestations that are significant enough for them to go to their physician for management. And again, there's no medical treatment. You have to ablate the lesions with a variety of different chemicals that actually destroy the infected tissue. And that's one of the difficulties of treating genital warts. I've already mentioned juvenile recurrent respiratory papillomatosis, and then I've already mentioned that you see a variety of different intraepithelial lesions of increasing abnormality, which ultimately lead to cancer. So this is a slide that shows the number of cancers reported in the United States each year due to HPV. And you can see that the most common is cervical cancer. So in spite of PAP testing and in spite of a program where we ask women to undergo PAP testing on a routine basis from age 21 on, it turns out that there's still over 10,000 cases of HPV-related cervical cancer diagnosed each year. And unfortunately, that results in about 4,000 deaths each year of women who have cervical cancer that's already too far along for local therapy to remove the infected tissue. In addition, there's a significant number of cases of oropharyngeal, anal, vulvar, and then vaginal and penile cancers each year in the United States. To look at it based on frequency in men or women, you can see that the overall burden of disease is higher in women, but in men there are over 9,000 cases a year, so that's enough to clearly indicate that prevention of cancer in men is just as important as in women. Cervical cancer, again, the most common, but women also have vulvar, vaginal, anal, and oropharyngeal cancers as a result of HPV infection. In males, the predominant site is oropharyngeal. Over 75% of the cases of HPV-related cancers in men are in the oropharyngeal area. Anal and penile cancers also represent the rest of the sites of involvement. Also, if you look at the percentage of cases of cancer at these different sites, you can see that HPV is responsible for the vast majority of cancers that occur in the anogenital area and in the oropharynx. And actually, the latest data is that over 70% of oropharyngeal cancer cases occur as a result of HPV infection. In addition, because the rate of oropharyngeal cancer is increasing each year, it looks like that by 2020, if the rates continue to evolve the way they are, oropharyngeal cancer cases will increase in number to eclipse the number of cervical cancer cases that are occurring in the United States. So if we look at cervical cancer incidence rates in the United States, you can see that there's a distribution based on parts of the country. The darker color states here are states with the highest cervical cancer rates. You can see Louisiana is one of the states in the darkest color, indicating that we have one of the higher cervical cancer rates in the United States. So if you want any other additional data to tell you how important it is for us to use HPV vaccine in this state, it's because we have one of the highest cervical cancer rates in the country. And as I mentioned, over 10,000 cases a year and over 4,000 deaths in the United States. This is the overall rate of cervical cancer per 100,000 women. And you can see that there is a distribution of cases based on race and ethnic backgrounds. The highest rate of cervical cancer is amongst Hispanic women, followed by black women, but you can see that the rate is very significant across all ethnic and racial groups. So this is a slide of cervical cancer incidence and death rates in the United States in 2012. And this little line that you can hardly see is the average rate in the United States of cervical cancer and the average rate of cervical cancer-associated deaths. And here's Louisiana in both of those charts. So you could see we're at the high end and above the national average. And again, another reason why we need to be aggressive in terms of using vaccine to prevent disease. So I've already alluded to this data, cancer-related trends in the United States. Cervical cancer rates are decreasing because of the use of PAP testing, and now in some cases the combination of PAP testing plus HPV detection. And yet, as I mentioned, there's still over 10,000 cases a year. Anal cancer rates increasing in both men and women, and at a rate of about 2.7% per year. And as I mentioned, oropharyngeal cancer rates are not only increasing significantly in men and women, but are likely to eclipse cervical cancer rates by 2020. So we know that the individuals become infected with different HPV types shortly after onset of sexual activity. But as you can see, it takes a number of years following the infection to when cancer develops related to the infection at the local site. So this shows you that the median age at diagnosis of cervical cancer is age 48, and for the other cancers that occur related to HPV, it's an older age group in the 60s. For males, oropharyngeal cancer, the median age is 58, but for anal and penile cancer, 56 and 68. So a number of years following infection before cancer is likely to develop. So that's the background in terms of epidemiology, clinical manifestations, and the significant role that HPV plays in development of cancer. And now we can talk about prevention. We have an opportunity to eradicate about 90% of cancers associated with HPV with the current vaccine strategy that's available. So we're going to talk a little bit about the vaccine, and then the recommendations, and then, as I mentioned, we're going to show you where we are now in terms of uptake and outcome of vaccination. So HPV vaccines are made up of what's called the major capsid protein, the L1 protein, of the different types of HPV that are within the various vaccines that are licensed. This was developed based on the fact that it turned out that the L1 major capsid protein is a very strong immunogen and results in a very significant immune response in actually initially in a series of animal experiments that showed that not only did the L1 protein produce significant antibody response, but it resulted in protection when the animal was given HPV through a inoculation exposure. The L1 protein has now been placed in using recombinant DNA technology. The gene for the L1 protein has been placed in a L1 producer cell. The Merck vaccine has been placed in baker's yeast, which uses the same technology that Merck used when they developed the hepatitis B vaccine. And GSK, with their vaccine, has used a insect cell line to produce the L1 protein. So the L1 protein is produced in a DNA recombinant cell line. It is purified, and then interestingly in the laboratory they're able to make it reassemble into a viral-like particle. So it has the size and shape of the HPV type that is responsible for the natural infection, but it's an empty shell. It has no DNA, so therefore it can't cause an active infection, and it's just the L1 protein. But these reassembled things are called viral-like particles. They resemble the virion, and that's probably what makes them so immunogenic, because they actually look like the virus to the immune system. But unlike the natural infection, the antibody response to these antigens is much, much higher than occurs with natural infection. So you get a very significant immune response to virtually every recipient of the vaccine. So high antibody levels, and now with ongoing studies of initial cohorts of women and then men who were immunized, we know that this antibody lasts for 8 to 10 years, and these are in ongoing studies. So with the decay curve that has been developed, this vaccine looks like it's going to act like the hepatitis B vaccine, where the primary series is likely to provide protection for a minimum of 20 years and perhaps even lifelong protection. So it looks like the 3-dose initial series is likely to provide very long-term active protection. So there are 3 vaccines that are currently available, and there is a transition going on. GSK developed a bivalent vaccine which contained only 16 and 11, and they targeted women to prevent cervical and other anogenital-related infections or cancers in women. And so this vaccine is only licensed in women. It's licensed as a 3-dose series. And actually, in the United States, this vaccine is used by less than 2% of providers. And the reason is that the Merck vaccine, they developed a different strategy. They included 16 and 18, but they also included 6 and 11, which are responsible for genital warts. And then they did trials in both men and women. So they had a vaccine that was licensed for both males and females. So to have one vaccine in your refrigerator that can then be used for both men and women is a much better strategy than having one for women and one for men. So very few people use the GSK vaccine in the United States. They're priced about the same, and so there's a real advantage to using the quadrivalent vaccine produced by Merck. So Merck, in addition to development of this vaccine, they began studying how many types of HPV you can actually put in a vaccine to get a good immune response. And so about 1.5 years ago, they presented data that led to the licensure of a new vaccine. So the quadrivalent vaccine was called Gardasil. The new vaccine is called Gardasil 9, and it contains 5 additional oncogenic types of HPV. So again, a further advance. Merck is phasing the quadrivalent vaccine out, and it's very likely there will be no quadrivalent vaccine available by the end of this year. So the only vaccine that will be available from Merck will be the 9-valent vaccine, and in fact, most people are already using the 9-valent vaccine exclusively, no longer ordering the 4-valent quadrivalent vaccine. The licensure for the 9-valent vaccine is 9 through 26 years of age in both men and women. And again, it's a 3-dose series, a little different. Instead of the second dose being given 1 month, it's given at 2 months after the first. So if we look at the types that are in the 9-valent vaccine, 16, 18, and then the next 5, we now can prevent 90% of HPV-associated cancers because these types are responsible for 90% of HPV-related cancers. Type 16 and 18 not only are important for HPV cancers, but they produce by themselves approximately 50% of the CIN2 or greater lesions that are seen in women in PAP testing. The next 5 types, 31, 33, 45, so on, they're responsible for about 14% of HPV-related cancers in women and about another 25% of CIN2 or greater, and about 5% of cancers in men. So the new vaccine is going to have a bigger impact in women than in men, but the 4-valent vaccine and the 9-valent vaccine both have type 16, which is responsible for most oropharyngeal cancer, and that's why the new vaccine is not going to have as much of an impact in men as it is in women. And as I already mentioned, 6 and 11 are responsible for 90% of anogenital warts. So how good are these vaccines? These are just the general results of vaccine efficacy that's seen in vaccine trials that led to the licensure of the bivalent and then the quadrivalent vaccine. So when they began to design the trials for these vaccines, number one, the epidemiologic data on oropharyngeal cancer-related HPV was not available, so the vaccines were really studied to look at anogenital cancers, not oropharyngeal. Number two, when somebody has a precancerous lesion, you don't let them have the lesion, you take it out. So cancer couldn't be an end point for the vaccine trials. What the FDA allowed was that precancerous lesions would be the end point for trials of these vaccines, because when someone had a precancerous lesion, you needed to do the surgical management that would be required to prevent that patient from going on to develop cancer. So the end point for vaccine efficacy were precancerous lesions. So you could see for cervical precancer due to types 16 and 18 with the bivalent quadrivalent vaccine, over 93% efficacy in preventing precancerous lesions. Vulvar vaginal precancers, quadrivalent vaccine, 100% protection. For anal precancers, 75% protection in males, and for anogenital warts, almost 100% protection. Pretty remarkable. And then when we look at the new vaccine against these 5 additional serotypes, same data. High-grade cervical vulvar vaginal disease, almost 97% risk reduction. High-grade CIN, adenocarcinoma in situ, cervical cancer, 96%. Persistent infection, 96% reduction. So again, really remarkable how effective these vaccines are in preventing primary infection with HPV and precancerous outcomes in the group. So for the 9-valent vaccine, to get it licensed, they had to prove that the response to type 6, 11, 16, and 18 were not inferior, the antibody response, to the 4-valent vaccine, and they did. And over 90% of the individuals who received the vaccine responded to all 9 types. So they got a good antibody response to all 9 types. Safety, these vaccines have been well tolerated. In all of the clinical trials that led to licensure, the main side effects have been local pain, tenderness at the injection site, some low-grade fever, but they've been very well tolerated. For the 9-valent vaccine, there's a slight increase in mild to moderate injection site AEs, but overall well tolerated. And then for young individuals, the reason we can give this vaccine to young individuals who we can't prove protection because they're not sexually active, they look at antibody response. So if you look at antibody response in the group that's protected, and then antibody response in the group that's younger, if the antibody response is the same, then it's called immunobridging. You bridge the potential of protection to the group that got the antibody response that were not exposed to HPV. And in fact, if you give this vaccine to 11 to 15-year-olds, the antibody response is actually even higher than when you give this vaccine to 16 to 26-year-olds. So young adolescents get a really good response, and in fact, that antibody remains pretty high over the next 8 to 10 years. And now in one prospective study that Merck has done ongoing in Norway of young girls who were given the vaccine at age 11 to 12, as they're becoming sexually active, they're protected against HPV. So we have lots of data that show that the immunity is long-lasting and protective for at least 8 to 10 years. Now, although we don't have data on prevention of HPV outcomes in oropharyngeal area, we do have one proof of concept piece of data. When the bivalent vaccine was studied, one of the study sites was in Costa Rica, and once the epidemiologic data became clear that HPV was related to oropharyngeal cancer, they did a post hoc study so that when the women came in for their 4th year visit, they were being followed for 5 years in this vaccine trial. 4th year, they added an oropharyngeal wash just to look for type 16 and 18. So the women were still blinded. 91, almost 92% of the eligible women participated, were still involved in the study. That was over 5,800 women. And they were looking only for evidence of prevention of oral infection. And what they found was in the control group, there were 15 infections with 16 and 18. Vaccine group only 1, showed a 93.3% efficacy against prevalent infection with type 16 and 18. So at least proof of concept that the vaccine will protect another mucosal site against HPV. And it would be expected that that would be the case, but this is the only proof we have of that at the present time. So safety, in the United States alone, over 80 million doses of quadrivalent vaccine have been distributed, over 7 million of 9-valent. There are a number of post-licensure monitoring programs in the United States, none of which have reported any significant new related adverse event other than what was identified in the clinical trials, except for 2. And number 1 is what we expect with any biologic product. There is a anaphylaxis rate of about 1 in a million doses, which is very consistent with other vaccines that we give. And then number 2, when we give any injection to an adolescent, many adolescents have a syncopal episode following that injection. So it's not the vaccine itself, it's the injection. This happens with any, I'm sure it happens to young adults as well. I don't know when the transition ends. I don't think it ends on your 18th birthday. So that you always remember when you give an injection to somebody, you always consider the possibility that that may induce a syncopal episode. So what we do in pediatrics is we make those patients sit for 15 minutes following the injection, because most syncopal episodes are going to occur within the first 5 minutes. You don't want somebody to get a vaccine or another injection, and walk out of the clinic, get out the front door, have a syncopal episode, and crack their head on the concrete of the sidewalk. So you want to keep them there for 15 minutes. They get past that syncopal episode. Pregnancy registries, also very important. A number of women who receive this vaccine become pregnant in the middle of the vaccine series. It turns out that there's really good evidence that there is no untoward effect on pregnancy in terms of outcome of the pregnancy or fetal abnormalities. So I think that it's very clear that the vaccines are safe, even though they're not recommended for pregnant women, and we'll talk about that in a minute. The CDC has done a prospective study looking at things that people have been concerned about that might be associated with the vaccine and have found that none of them are associated with the vaccine, comparing 600,000 doses of vaccine versus individuals who were matched who did not get vaccine. There was no increase in adverse events, any of these pre-specified adverse events. The vaccine registry for 4-valent vaccine has been closed because there was no safety issue. There's a new one for the 9-valent vaccine as well that's been established. So what are the recommendations? Current recommendations are that we want to give this vaccine routinely to all boys and girls at age 11 to 12. And that's because we want to get them before they're likely to become infected. Like any other opportunity, if you have a vaccine to prevent infection, you want to give it to people before they're likely going to get infected. 11 and 12 is a good age. You can start as early as 9 years of age because the vaccines are licensed down to 9 years. So if you think you got a higher risk individual, you can start as early as 9. And then current recommendation is to vaccinate all females 13 through 26 years of age and males 13 to 21 years of age who have either not started or who have not completed the HPV vaccine series. Males 22 through 26 of age may be vaccinated. So this is what the CDC is now calling, ACIP is calling a Category B recommendation, where it's not a routine recommendation, but a physician and a patient can sit down and talk over potential risks, benefits, and then choose to give the vaccine if they feel that it is appropriate. And this decision was really based on cost-effective analysis, where for women, it was clearly cost-effective to give through age 26, but for males 22 to 26, it was significantly less cost-effective. And so that's why that decision was made. On the other hand, for males 22 to 26 who are immune-compromised, who are men who have sex with men, they should be vaccinated because they have a higher risk of HPV-related disease and poor outcomes. So they need to be vaccinated. And then children who have been sexually abused, we also immunize them at age 9 years. Here's your 2016 adult vaccine schedule, and it says just that. 3 doses for females through age 26, and 3 doses for males up through age 21. And then in purple here is give this vaccine for people who have increased risk. So you can actually use any vaccine for the women, but as I said, 4-valent will no longer be available. 2-valent's not really used, so 9-valent is your primary vaccine, and for males, same thing. 9-valent will probably be the only vaccine that will be available pretty soon. You try and complete the series with the same product that you started with, but 9-valent can complete the 4-valent series. So additional recommendations, I've already talked about observing your patients for 15 minutes following the injection. This is not recommended for pregnant women, but you don't have to test a woman to determine if she's pregnant. If you start the vaccine series and then the woman becomes pregnant, you suspend further doses until the pregnancy is completed. Then you just go back and finish the rest of the series as recommended. And again, as I mentioned, 9-valent vaccine now has a new registry to follow pregnancy outcomes. So why do we do this at age 11 to 12? Well, as I said, we have a chance to capture people before they're likely to be infected. That's the best time to give it. Modeling shows that that will give you the best outcome in terms of reducing the total incidence of HPV-related cancers. You can't really target people to determine who's more likely to become sexually active in the next 6 months. It just doesn't work. So you give it to everybody and keep ahead of schedule for everybody. I already mentioned that the second reason is that they get a very strong antibody response, and the antibody lasts for a number of years. Vaccine's well tolerated, and it's an implementation advantage because we give a number of other vaccines at age 11 to 12. We give a Tdap booster dose and meningococcal quadrivalent vaccine. So there's a vaccine visit already at age 11 to 12, and you can start HPV vaccine at the same time. Unfortunately, what we're seeing, and this is why you all become really important, is that this is a survey that the CDC does each year looking at the uptake of adolescent vaccines. It's a phone survey, and you can see that 87% of persons age 13 to 17 have received their Tdap. 79% have received their meningococcal conjugate vaccine, but only 60% of girls have gotten one dose of HPV vaccine. Only 39% have gotten all three doses. For boys, it's worse. 41% have gotten one dose. Only 21% have completed their series. So we're behind. And it's interesting that we're doing well here, we're not doing well here. Why is that? It's because doctors are giving recommendations for HPV vaccine differently than they're giving for these other two. We need to fix that. And so on the pediatric side, we're working to try and do that, but unfortunately that means there are a lot of 18-year-olds who are getting into your practices that are not immunized, and we need to catch them up. Here's Louisiana. This is every state on that survey. We're on the lower left-hand corner in terms of the number of adolescents at age 17 who have started their HPV series. Not completed it, but started it. And the sad part is that if we look at the number of girls at age 13, so they had ample time to have been given the 3-dose series of HPV vaccine. But if we're looking at the missed opportunities, 91% of them at age 13 had gotten Tdap and meningococcal conjugate vaccine. Only 47% have started HPV, which means that we're missing an opportunity. They're coming in for vaccine, but they're not getting HPV vaccine. And that's a real problem that we have to work on. One of the problems that providers have is that they think that parents are nervous about HPV vaccine and don't want to get it for their young 11 to 12-year-old. This is a study that was done in Houston by Mary Healy, and they asked parents how they valued vaccines on a scale of 1 to 10. And you can see for HPV vaccine, they were just as high, 9.3, as for other vaccines. And they asked providers to estimate what parents thought about the vaccines. Providers think that parents don't want HPV vaccine, but it's not true. So providers need to make a strong recommendation for HPV. So providers need to be familiar with HPV and what it causes, understand that the vaccine is valued by parents, and you need to make a stronger recommendation for HPV vaccine as you do for the other two. And that usually is going to solve the problem. Parents need to realize that HPV vaccine is cancer prevention, so rather than talk about HPV as a sexually transmitted disease, our recommendation is that you tell parents that at age 11 to 12, I have 3 vaccines that your child needs today. They need HPV vaccine to prevent cancer, Tdap to prevent pertussis, meningococcal vaccine to prevent meningitis. And for most parents, that's enough. And if they ask you questions about HPV, it doesn't mean that they're hesitant. It may mean that they've heard something, they need more information. So don't back off. If a parent asks a question, they may need information. So, and then the last thing that's important about HPV is these other vaccines, they're a 1-dose series. HPV needs 3 doses. So you got to figure out how to get patients back to your office. So very quickly for the end, I want to just show you some outcomes. So we're not going to see the big effect on cancer with HPV vaccine for another 10 to 20 years, because that's how long it takes for cancer to develop following infection. So the only way to know how effective the vaccine is to start looking at early outcomes. There's been a change in HPV prevalence. with the vaccine types? Is there a change in genital warts? And are we seeing changes in cancer precursors related to the types that are in the vaccine? And so this is where we are looking at early and mid outcomes. So this is the most recent NHANES study, which was just published a couple of months ago in Pediatrics. And what it shows you is that if we compare the incidence of vaccine types in 2003, 2006, before the first vaccine was licensed, which was in 2006, to 2009, 2012, same cervical vaginal swabs. In the 14 to 19-year-old group, there's been a 64% decrease in vaccine types on cervical vaginal swabs. For 20 to 24-year-olds, a 34% decrease, and for greater than 25-year-olds who are unable to get the vaccine because they're already at the older age group, no decrease. For 16 and 18, it's dropped from 7.1% prevalence to 2.8%. And if we look at sexually active unvaccinated versus vaccinated, marked reduction, vaccine efficacy of 1 or more doses, 89%. So population effect, pretty dramatic, even though only 50% of individuals are even starting the vaccine series. And then the 5 new types that are in the vaccine, you can see prevalence stayed at about 13%. So right now, there's no evidence of strain or type replacement with the use of vaccine. So that's good news so far. Incidence of genital warts amongst people visiting the physician for management. 2 age groups, there's been a drop, the 10 to 14-year-olds and the 15 and 19-year-olds. If we look in Australia, they started a program where they gave the vaccine free to girls in up to age 26, and you can see they started the vaccine program. This is the drop in incidence of genital warts for the girls who received the vaccine, and actually their male partners had a significant drop as well. Herd immunity, good example of protection. But amongst males who had sex with males, there was no change in overall incidence. If they look 5 years into the program, almost no girls have genital warts. And actually, the only people who have genital warts are the unvaccinated girls. The vaccinated girls, no cases. Significant decline in young girls. The decline in boys continued, but again, because of the fact that there was no decline in either men who have sex with men or bisexual men, Australia began immunizing men as well. And so now they have both men and women, boys and girls, being immunized. Mid-evidence of impact, 40% reduction in vaccine type prevalence in 20 to 29-year-old women screened with liquid cytology, and even lower if vaccinated, and a 33% in adjusted prevalence rate for 16 and 18 and 18 to 31-year-old women vaccinated more than 24 months before getting a PAP test. So again, we're beginning to see that change as well. Population impact for genital warts, prevalence, and cervical lesions, multiple countries throughout the world. So, key points. HPV-related cancers are common. They're a result of a common infection. Vaccines are safe, very effective, and many 18 to 26-year-olds coming into your practice are not immunized. You need to find them and give them a chance to either complete the series or get it started so that you can offer them protection. Even if they've been sexually active, the chance that they've been exposed to all of the types that are in the vaccine is still pretty small. So although you won't get the same degree of protection as if we immunize them at age 11 to 12, you can offer them some significant degree of protection against the types that they have not had as of yet. There's no need to screen them before you give the vaccine. You just give the vaccine. So I'll stop there and see if there are any questions. Yes, sir.
I have a messaging question, especially since we'll be taking care of women who are at age of being pregnant. The message to say we don't have to screen you
Yes.
if you're pregnant. However, if you are pregnant, we're not going to give it to you. That would produce, if I was a woman, I would be conflicted saying, no, if you know I'm pregnant, you're not going to give it, then why should you want to know if I'm pregnant? How do you handle that messaging?
Well, we run into this all the time with live attenuated vaccines and other things. And I think that, whoops, I don't know who did that? The vaccine is clearly safe, but it's never really been studied in pregnant women. So that's why there is no recommendation for giving it in pregnant women. I think that the way I would approach that is if a woman is sexually active, thinking and not taking precautions to prevent pregnancy or wants to become pregnant, make them aware that the vaccine is not recommended if they are pregnant. And if they want us to wait until they decide or become pregnant, have that pregnancy, that's one way to do this. On the other hand, if they are sexually active, taking precautions, I think you can make it clear that you're going to start the vaccine, but if they do become pregnant while they're receiving the series, you're going to stop the series until the pregnancy is completed. And I think you have the backing of the CDC, the ACIP, the American Academy of Pediatrics, ACOG, everybody agrees to this approach. And so I think we didn't want to burn. I was involved in making these decisions because I was lucky enough to be on ACIP when all these decisions were being made. And the goal was not to put too many impediments or barriers to the practicing physician, to make it as simple as possible. Okay, yes, sir.
What's the relative efficacy if they start but don't complete the 3-dose series?
That's a really good question. And it turns out that the longer you wait between the first and the second dose, probably the better efficacy that you might achieve. When this vaccine was first developed, they followed the same protocol that they did for hepatitis B vaccine. One dose, 1 to 2 months later, and then 6 months. And that was based on the fact that they thought you needed 2 priming doses to mature your memory cells and then boost with mature memory cells to get a good response. Well, it turns out that the vaccine is so effective that in young individuals, we're now looking at data that suggests that a 2-dose schedule is probably going to be enough if the second dose is delayed till 6 months. And the antibody response and the protection appears to be good even if you wait longer to 12 months. But that's primarily going to be for individuals who are under 15 years of age. So the data that I showed you, again, from the NHANES study, this was not a prospectively followed population. So this is just population of individuals. But you saw that for 1 dose or 2, that the efficacy appears to be as high as 89%. So there is some degree of protection after the first dose and maybe even better protection after 2, but we don't really know exactly what that's going to be because it's not been prospectively studied. But there have been, because of the data that's available, I don't know whether they're being kicked out or what, the data that's available for the 4-valent and the 2-valent vaccine in Europe, and the World Health Organization for women is recommending a 2-dose schedule for girls under 15 because of the fact that you're going to get a significant degree of evidence of protection. Yes, sir.
Is there any consideration of expanding the upper limit of age for the vaccine? Yes, I know that people are sexually active, but you also said that it's rare to get exposed to every one of these serotypes. So is there a concept of expanding that out to catch some of those people too?
Yeah, James. Actually, both companies studied the vaccine in women up through, I think, age 45. And the vaccine did prove to be effective. and safe in the age group of 27 through 45 or whatever, but the number of endpoints was small enough that it didn't appear to be cost effective for the general population of women in that age group. On the other hand, if you have someone who is at increased risk, there's no reason why you can't give the vaccine to an older age woman who is at increased risk. It'll be off-label, but it's still okay.
And the reason I ask is if you look at inflammatory bowel disease patients, they have a higher risk of cervical cancer at baseline,
Yeah.
regardless of the immunosuppression. So I'm trying to reason out for some of these patients, is it reasonable to go ahead and vaccinate?
I think there'd be no reason to, you certainly can give it. Again, it'll be off-label, and the insurance company may not pay for it, but it could be very valuable. So I don't think it's unreasonable to give it. Like I said, it's been studies already done to prove that it's safe. Okay, thank you.